Good afternoon and welcome to actually the last of the 65 conferences of iCAAD this year. I'm very, very proud and honored to be the facilitator today. My name is Kostas and I'm one of the iCAAD director. And today we're going to talk about, I'm going to summarize maybe this title, which is a little bit confusing maybe. Global integration, which means basically that we've been developing so many activities around treating addiction. But the more we do that, the more also academic research, brain research, a lot of research says, well, maybe it could be more efficient to try to see that globally from the mental health perspective. And there's a lot of good academic research about the brain functioning informing that. But today what we're going to explore is what is the future for treating addiction? Do we integrate? How does this loops and links between mental health and addiction? Is addiction disorder treatment discrete or has to be globalized? In order to do that, today we have three great experts, and we were supposed to have a fourth one, James the Bass, who is poorly in bed, so he sends all his apologies. So we'll have just to forget about all the future of e-technologies and what he built, but he'll come back another day. So to talk about this major issue and what's going to happen next, maybe, we have today Ray Tamasi. Thank you. Welcome again. And Ray is the president of Kostas on Cape Cod, and he's been for 35, 40 years. 25? Oh, sorry. Long time. I'm not very diplomatic today. I don't know what's happening. Anyway, I'm sorry for that. Yeah, a long time becoming an authority in treatment, intervention, prevention, and developing services in the United States of America. He will share more about his experience of this question: where are we going with addiction treatment as a standalone? What are the options? What did we learn on the other side of the pond? So then we'll have, speaking more maybe for the UK, Dr. Kostas Agath, Medical Director of Addiction, and a significant long experience in psychiatry in England, in the UK, with an endless list of responsibilities and achievements. They come together usually. Who will speak about the UK and where we're going here. Least but not last, Gail Jones, who's the Deputy CEO of RAPT, will speak of a very specific experience which makes a lot of sense to our world, was what do we do in terms of mental health in addiction in a very closed system, prisons. There's a lot of things that are fantastic that have been done by RAPT over there in prison. I'm quite familiar with that, and I'm very admirative. And I suppose my point here is that it's a place where you have someone for a long period of time, right? So it's a place where if they don't run away, it's a place where you can explore deeply things. So it might be a little bit of a one example, but actually it is not, because this is a fantastic way to explore human nature, and I know from your slide that you're going to explore that. So this is what we're going to talk about, and I'm just going to share with you a bit of information. I made some research because this is what I do, and I came with some interesting, I call it concerning facts. 37% to 50% of personality disorders prevalence in alcohol and substance misuse services. I'm sorry, I've been stuttering in my slides. And I'm quoting Owen Bowden-Jones, who was speaking yesterday, by the way. And we've got another view, which is let's score the substance misuse in mental health treatment unit. And it's not very dissimilar, 22% to 45%. So there is a huge evidence of coexistence. And bizarrely, I never find a unicity in the research. It's always coming either from the world of misuse treatment or either from the world of mental health, which suggests that there is not a global integration at that stage. Another thing that is interesting, the dual diagnosis of comorbidity in trying to integrate mental health in addiction still applied very pragmatically. There's a lack of standards, a lot of local definitions, and I'm quoting a research of 2004 of Todd and alumni. The other thing I found is that, again, mental health addiction, dual diagnosis, is a generic index of complexity, and that's a quote from Rasul, who's been providing a lot of paper and research around this problem. And last but not least, there's still a debate in NICE and HS, recommendation excluding when it comes to comorbidity, personality disorders compared to SMI. So that's again, I'm quoting Megnan and Agath here, and that's quite concerning in terms of global integration. So I wanted to share that with you. And then, in order just to give a bit of background around all that, I find a few quotes. I find them very relevant to our topic tonight. That's Aubrey Lewis, Monument of English Psychiatry. He wrote in 1963, the barrier to conspicuous advance in psychiatry has not been lack of ability amongst those who are engaged in psychiatric research. It lies in the inherent toughness of the problems. It's hugely complicated what we're discussing today, the mental health, and therefore psychiatric answers to that. Second one is from Carl Jaspers. Observation is not enough. If we are to obtain some clear communicable concept, and if we are to reach an adequate differentiation of our field, valid thinking, in addition, is essential. Otherwise, no advance in our knowledge will take place. And this is what we're aiming to do tonight, I think. Last but not least, when we are no longer able to change the situation, we are challenged to change ourselves, as Viktor Frankl. And maybe also this is what profoundly this panel today is about, the process of change. How can we evolve and let go of old behaviors and old protocols and clinical vision into new ones is definitely not easy. So, first of all, I will ask Ray to speak for the USA, and then Kostas to join with the UK. Then we will address the prison situation with Gail, and we will leave for another day, another year, the e-solutions and the work of John DeBase. Maybe he's listening at us online, I don't know. We can salute him maybe. And I think that's it for me. Ray, can I hand it over to you?
You can do that.
Thank you. So I'm just looking at this, and you are here. I just need to go on. Sorry. Oops. Here we go. Good. Thank you. I think it should be.
Thank you, Christophe. I think I'll try to stand behind this. I'm a roamer, but I will stay put. So as I was thinking about this earlier, and certainly before this conference, I think it's and then listening to we had a panel just before this. Some of you, I think, may have been at that. It's a very critical time, certainly in the U.S. for addiction services, addiction treatment. I want to show you some slides that I showed in the first session. Gives you a little bit of a perspective of the scope of the problem and the complexity of the problem. And it comes at a time when the treatment system in America is certainly it's been around for over 40 years. It officially sort of began in the early 1970s. It's built on an acute care model. It's been expanded based on that model for many, many years. And we are at a time now when suddenly we're recognizing that we're not really treating an acute illness. We're treating it in acute episodes, but we're treating a chronic illness that requires a range of services over the course of the life of the disease. And I think that we're at a place now where we are going to start to see changes in the way that treatment is delivered. We have an opportunity to influence what those changes are like, and I think it's an opportunity that comes, frankly, once in a generation. We can blow it, or we can take advantage of the opportunity to redefine the system in a way that much more effectively and satisfactorily treats people who not only have these conditions in their acute state, but also it does much better in early identification, prevention, early intervention, and long-term sustainability in recovery management. So very quickly, because I don't want to spend too much time on this, but we have the distinction of being the most opioid abusing country in the world by far. 50,000 overdose deaths a year has driven this issue to the front of the headlines and to the highest levels of government. Governors, presidents, we don't know. The last president, yes, we don't know about this one, but it's certainly the public has taken an interest in this, primarily because of the impact among a large section of the socioeconomic strata. It's not strictly a problem that's relegated to marginalized groups. It's throughout the society, and in fact, the most impact has been on white middle class and upper middle class individuals. Overdose trends, which have been categorized as epidemic in the last 3 years, really have been unacceptable for almost 20 years now, with prescription opioid overdose deaths in 2003 roughly equivalent to the overdose deaths from heroin in 2013. You can see that all of this is directly related to the advent of the overuse of pain medication and the overprescribing of pain medication. In our country, this phenomenon was driven initially by the national accrediting body, which determined in its ultimate wisdom that not enough was being done to evaluate and treat pain, and they then applied a standard that was required of all healthcare institutions, that you need to begin to assess for pain, and depending on what that assessment produced, you needed to treat for pain. That led sort of the capitalist spirit that we have to think about developing medications to treat this pain, because the more you ask people about pain, the more people are in pain. And so here we had a spiral that went out of control, almost based upon one paper that said that the likelihood of addiction to opioid pain relievers was less than 1%. So doctors could feel comfortable in prescribing them because they really would have very little long-term effect on people. The paper was based upon data from patients who had gotten the medication for 3 or 4 days in a hospital. There was really nothing that was done to look at long-term use and the impact of long-term use. And so you see a corresponding, parallel course of sales deaths and ultimately treatment. This is telling because it shows, primarily due to the opioid overdose deaths, that life expectancy in the United States has now gone down for the first time in many years. This has a much greater impact on our population than simply those people who use drugs. And there still is that stigmatized perception that exists, certainly in every country. There's a staggering graph that shows all-cause mortality of middle-aged individuals. The United States numbers are going up, primarily due to the opioid problem. Here is the rising, the surge really in mortalities by overdoses, suicides, chronic liver disease. All these numbers are very disturbing, and they have not been widely distributed or understood by policymakers and the political. This is actually from Angus Deaton's work. He's the guy who wrote the Great Inequality book, a Nobel Prize-winning economist. Here are more certainly graphic representations of the impact of this crisis. We have poisonings, overdose deaths, the rising red line, and the others that are all going up. So all of this is impacting much beyond what we traditionally associate with drug-using individuals. I thought this was pretty impressive. Half of the men who aren't working or not in the workforce are on prescription opioid medications in the United States. That actually translates to something like 15% of all the adult males in the country. That's a shocking thing. The impact on productivity, economic output, all of the things that historically are of greater interest to policymakers is directly related to the kinds of things that we work in and we see every day. People who cannot function and who are not healthy enough really to function. So we have a very, very sort of scattered prescription pattern in the U.S. The dark states are they're all over prescribing. I mean, Massachusetts is 7 million people, and last year we distributed 250 million prescription opioid pain medications in the state. That's enough to supply every individual in the state with a month worth of opioids. And we have a very progressive governor on this issue with a very aggressive policy on limiting first-time prescriptions. But still, the state of Ohio we read in the newspapers on some days the state of Ohio is 7, 8, 10 overdose deaths in one day. So it's a national epidemic that has not really been perceived that way and has not been resourced that way. Much of it because of the stigma associated with addiction and the misunderstanding that people have about people who have this illness. There's still, despite awareness efforts, advertising efforts, Massachusetts now has billboards all around that say, addiction, it's not a choice, it's a disease. When you really drill down in conversation with people, it's still about those people making bad decisions for themselves. And I think that that has been part of the reason why it's very hard to drive these kinds of changes into the culture. The way we view these conditions in America is deeply rooted in the culture. It takes a long time. It's happening, but it's not something that goes away overnight. I don't know if you can see that. So there are a number of states that have actually passed legal requirements around prescribed opioids. First-time prescriptions limited to no more than 7 days. One of the backlashes of this is that there are physicians now in America who are advising their patients they will no longer prescribe opioid pain medications, which is part of the pendulum swinging almost too far the other way, because there are patients who need these medications to manage pain, and they are having great difficulty. They'll go to the pharmacy to get their medication, and they'll be looked at suspiciously, and so they're being sort of compartmentalized into the stigmatized view also. We did this before, so we want to skip those. So I think, what is the place for specialty addiction centers? In America, we've got somewhere in the neighborhood of 20,000 treatment programs. After hearing Elif from Turkey and Noreen from the UK in our last panel session, I felt almost, boy, we're pretty lucky. We're pretty lucky in America. There are a lot of things that you can find wrong with the way the system operates, but there are services, and there are a lot of organizations that provide services, and I guess I would say that those services are pretty robust. Most of them are focused on dealing with crises, and so you often hear in America, we need more bed capacity because people can't get into treatment. There's not enough access to care. And I look at that and I say, well, if the only time someone tries to get access to care is when they're in an emergent situation, they need that care right away. And almost there isn't a system around that is consistently able to provide immediate access at the very point at which someone says, I need to get the care today. You almost can't have enough beds to do that. And if you look at our system in America, it's, as I said, most of it's based upon an acute model. So most of the services that we provide are perceived by the public as being necessary when someone needs to be hospitalized. The nature of addiction doesn't lend itself toward, gee, I know, I have a family history of addiction, and maybe I'm drinking a little bit too much, so I think I'll go to my physician and we'll have a conversation about it. That's probably not going to happen. In our country, if you go to the doctor, I would guess that half of the doctors would say, no, Jack, you don't have a problem. You're not like those people. So I don't even know if that would help. So the medical profession has been pretty, I'd say, fairly categorized as not being sympathetic and certainly not being knowledgeable. We heard the other day in one of the sessions, a fellow got up and said that, it's accurate. In medical school, you might get 2 hours, an hour or 2 hours of training on addiction. There's very little in how to manage pain properly. So we have physicians that are not informed, not terribly interested, and probably been burned by the alcohol-dependent patient by not showing up or by not paying the bill. So it's been disinterest. That disinterest led a group of people many years ago in America to say, okay, well, we don't need the medical profession. We'll build our own system. And so we built a system of care that was outside of health care as we know it, sort of on the sidelines, operating in a whole other place, and we began to provide services, and they're good services. Are they equal to the task today, and what should they look like tomorrow, and to what extent are existing organizations ready to respond to that? So you may have seen this. This is fairly typical. Tom McClellan put it together many years ago from Treatment Research Institute. We estimate about 25 million addicted individuals in the country. About 18 million are alcohol dependent. About 10, it's now maybe 15% of those folks get treatment. The rest are not getting treatment. And then right underneath that group are another 60 million who we might categorize as misusers or abusers, who are getting nothing, who are in the general population, who are going to their physician, who are doing things. Their functionality is okay, but they do suffer consequence. If you talk to any other area of endeavor, and at one point in my career I worked for a cosmetics firm. That's right. Looking to develop new products that, at the time, mostly women would buy. If we saw a number like this, it said we have a potential market of 80 million people who are not getting anything, we would just salivate over that. And when I talk to people in what we call real corporations in the world of business, and I say, I don't understand it. You can't figure out how to get to those folks? We haven't really taken the time to figure that out. We're all focused on a very narrow sliver of the total addicted population, or the dependent population, or the misusing population, not to mention family members. So when you add all these numbers up in America, you've got about 45% of the population who is affected by addiction. Now this is one state, but this is pretty typical of most states. This is 1 year of admissions to detoxification centers. 40% of the people who were in those detoxification centers were the same people multiple times in the same year. Now we looked at that. I was appointed to the governor of Massachusetts, created we called it a working group. The current federal group has gotten together to form a commission, and then there are always task force, so they just go on and on. We actually came up with a number of recommendations that have been implemented, but they looked at multiple admissions to inpatient treatment centers. The number jumps out at me that if we were just able to reduce the repeat admissions of individuals, we would free up about 20,000 additional people could have gotten treatment. So the issue of access to care is certainly a challenge, but the answer to access to care is better care, better wraparound services, and lower readmission rates to inpatient programs. That challenges existing specialty centers to be thinking more about what happens after someone leaves my rehab. These are the kind of things I think that will force us to be thinking differently. This graph represents essentially patients with medical problems. The lighter bar graph are individuals without a behavioral health comorbidity, and the darker ones are patients who have either one or two behavioral health comorbidities. And you can see that the readmission rates to hospitals are significantly higher. That has tremendous impact. In America, the Center for Medicaid Services has made a determination that they will not pay hospitals for patients who return to the hospital in less than 30 days for a condition related to the one for which they were treated. Last year, 55% of the hospitals failed to meet that target and paid a penalty for it. If you're a hospital administrator and you're looking in the data-driven world that we exist in today to look at your patient population and where those readmissions are taking place, this kind of stuff jumps right out at you. And so hospitals who heretofore have been rather, I'm talking general med-surg hospitals, have generally been disinterested in treating behavioral health disorders or in even partnering with specialists who are going to begin looking at that differently. Why? Because it's going to cost them. They assume risk and they pay a penalty. If you don't have expertise and you don't have compelling interest in wanting to treat these conditions, your staff, we've done many trainings in hospitals with physicians and nurses. They don't really know and they don't really enjoy treating patients who have behavioral health disorders. First of all, they don't act like patients, just lay there and wait for people to do things to them. They say, no, I don't want it. They cheat the medication. They drive you crazy. I remember once we were in a session and a doctor said to me, he said, Ray, he says, come on. He says, patients only go to your treatment center because they have to. They don't really want to go there. And I'm like, oh boy. And I said, you know what, Doc, why don't we go up to the ICU in this hospital and we'll ask the patients, were you looking forward to coming here? No one wants to be in this hospital. No one wants to be in a rehab. No one wants to be in a detox. But that's the perception. This is going to change that. If you look at this another way, these are some medical conditions here: COPD, pneumonia, renal failure, kidney disease. The light number is what are the readmission rates for patients with these medically diagnosed conditions if they have one or both comorbidities with addiction or mental health illness. They're significantly higher. And so we've now been called into some of these settings to say, can you help us with this? If you look at emergency room admissions, the predominant admission in an emergency room generally is an alcohol-related condition. So we said, well, you know what we'll do? We'll put an addiction specialist in the emergency room to work with your staff to intervene and engage with these patients to try to get them the services. They're like blown away. They said, we don't understand this. We can only get 1 out of every 15 people to say, okay, I'll talk to a therapist or I'll go to a treatment place. You're getting 7 out of 10 people to say, yes, I'll go to treatment. Why? Well, I said, you know, Doc, when the first thing you say to the patient when they walk into your emergency room a little inebriated is, don't act up in my emergency room, I'm going to call the police. That's probably not the best motivational interviewing thing to do. So, yeah, we know how to talk to folks, and they respond. In 1 year, we've seen a 40% reduction in repeat emergency room visits from the patients we've engaged with. That becomes a compelling sales pitch to the hospital. It's one of the ways that we can begin to move outside of our sort of confined special program into the wider world where all those other patients are, those 80 million patients. Here's the other thing about this. I think I want to say in terms of how we begin to think about specialty centers and how we can begin to maybe not redefine ourselves, but expand our vision. By 2025 in America, there will be a shortage of somewhere between 75,000 and 100,000 qualified workers to work in this field. People aren't going into the field. It's a high burnout field. It's a very low paid field. It's very challenging. At the same time, by 2025, the projections are that behavioral health disorders will be the leading cause of disability in the United States. We have a rising population in need, with better awareness, I must say, and a reduction in workforce capability. A lot of aging out, guys like me who are not being replaced. So how are we going to deal with that? We need to think about the role of technology, not so much to replace people, but to enable people to do their work better, to see more patients, and to fill in the gap between visits, if you will, in an outpatient center. So when we think about how do we maintain, sustain, it's integration with general medical care. We, in a very small way in our organization, have begun to do that. We embed clinicians into medical practices, community health centers. We're starting in the next month in a pediatric practice. Very exciting possibilities with that. Early intervention, screening, lifestyle managed modification, talking with parents. So integration with healthcare, adopting technology, developing services that produce better outcomes. It's not enough to go away for 3 or 4 or 6 weeks, and that's the end of it. You say, well, great, you graduate. We took that term out of our organization. You don't graduate from diabetes treatment. You get stabilized, you get normalized, you get on medication, and you move on with your life and you stay engaged. So engagement, integration, technology, thinking about moving away from the sidelines into the mainstream. I think it's going to be critical. There is a consolidation of addiction treatment centers in America, companies that are sort of buying up the mom and pop shops and trying to create market dominance, but they too will be challenged as payment gets related to the value you bring in favorable patient outcomes and not so much in how many beds you fill for how long. So it's a different way of thinking. I think I went over my time, but I went first, so.
Thank you, Ray. Can I
Thank you.
invite you to come, Kostas? Thank you. And if I got it right, yes, I'm going to go down with this. Yes, I think. I'm just going to move that. So we can just maybe see what's happening here. Oops, that's it.
Yeah, excellent.
If you
Thank you.
know-
Yeah. Many thanks.
Thank you.
Well, this works. Now, I'm going to talk to you about the same topic. It's going to be an entirely different angle. What I'm going to tackle this title, which talks about the need for sustainability regarding standalone addiction services. Do we stay there, or do we strategize beyond the existing activities, which means we're standalone operators? This is what I'm going to try and tackle within the next 20 minutes. This would probably work as well, yes? Here? Yeah. Otherwise I use a file. I use the done. So let's try. Yeah. Okay. We're almost there. Yeah. We don't record it. If we go back, then I'll Excellent. So let's see whether it works. It does. Okay, so I've explained to you what I'm trying to do. I'm trying to see whether we should stay standalone operators in addiction services, or to strategize. We need to try and think beyond our existing boundaries. And that will be a UK focus as per the instruction I got from Christoph. So approaching global integration, I'm going to talk about the challenges in the UK. And this is my first slide. Does anyone know what that picture depicts? It's one of my favorite photographs. Yeah.
Is it from the war? Sorry.
Yeah. Well, thank you. I mean, basically what it is about you have kids watching theatre puppets. Yeah. And it's the behind you moment. They are just turning away from the screen. There's something horrible happens there. And that's very important because they're kids. They master their fears by just moving away from them, trying to control them. What do we do as adults? We try to sort out our challenges, which is the equivalent of the childhood fears, by providing a solution framework. Unfortunately, children cannot do that in puppetry as yet. So I'm going to show you first challenges in the UK, and then I'm going to suggest how to bring everything together in a solution framework towards this global integration. Okay, 3 slides for the current challenges. First one, we have excessive comorbidity. We've heard that quite a lot of things about mental health, both Raymond and Christoph, but we do have physical comorbidity as well. As Ray highlighted towards the end of his talk, it's about problems with the lungs, with the heart, with the liver. People die from all sorts of things. Diabetes is around the corner in this country. In a couple of decades, 1 in 10 people would need treatment for diabetes. I suspect our clients would need that too. And they're aging as well. So, second big challenge we have in the UK is the difference between the personalized care and the pathways to treatment. So it's all wonderful to say we're going to treat people individually, but the concept of dealing comorbidity is based on pathways, is based on organizing a way of actually moving someone who's going to turn up in a particular point on the health system, for example, and get him to the right place. So if someone comes to alcohol problems, presents at A&E, we get in touch with someone who could help them out. Might be primary care, might be secondary care. That's slightly different from personalized care, where people might have all that extensive comorbidity and need need to be treated as more than one problems. The second current challenge we have is the third one up here is the juxtaposition of delivering specialism versus the care coordinator. We admittedly we have a sophisticated system in UK, and what happens is that people are fairly well trained in recognizing a lot of problems. The question is about, do they treat them? Would you actually create some sort of a care coordination framework? We broker more or less actions relative to where we are. That's another big challenge that we have here, again, because of the sophistication of the system. The next three challenges, I group them together because they have some similarities, as you've probably seen. It's the engagement versus crisis management. Behind this cryptic, behind this cryptic description, I found the word I was searching for, is the fact that traditionally what we are doing in addiction, we are operating on engagement. We are operating on the principle that someone would have been with us for a substantial amount of time, so would be able to help them out if they wanted to. Nowadays, with the new psychoactive substances, quite a lot of times we do crisis management. People do turn up because they have a problem, we have to address it there and then, and after that they get on with their lives because they have, they have recovery capital, they have jobs to go to, they have studies to go to, they have family to go to. It's a big change in UK. The next one is about the pharmacology versus the social prescribing. We're sophisticated enough to know that prescribing medication is not enough to sort out your problems. It might put you in a position to sort out addiction problems sometimes, but there's no solution for doing something with your life, finding an outlay, in just going out with peers and friends and enjoying life and having hobbies and work and things to aspire to. I think it's an important issue which is not being very well recognized. I mean, a classic example is that in medicine, what we learn about these mice that they are being cannulated in hamsters, in laboratories, and they stare inside boxes and they press levers for getting cocaine and alcohol and heroin, tens of thousands of pounds in order to get their habit right, And then again, try to leave the door of those cages open. The mice would disappear. We'd go hamster, we'd go and find other hamsters, have a party, walk on the wild side. They would never sit there just only for the medication. The third one is the confidentiality versus the risk management. I mentioned already the comorbidity and a lot of other problems that people have. It's one thing to be able to try and risk manage all their problems. It's a difficult thing to share the information you have about someone without violating their rights, to actually keep some things for themselves and the treating team. Again, a balance is needed and we're struggling with that in UK. Second slide of current challenges. It's never ending, I assure you. Diverse funding streams. Different actors are being funded by entirely different areas. And needless to say that there's a fundamental difference between the health and social care in terms of funding in this country. There's far more money being spent on healthcare rather than social care. And as I said earlier on, sorting out the biological aspects of one's problems, it doesn't mean that you give them solutions to what to do with their time and providing with aspirations. A further division is between the primary and secondary care. In this country there's been a move towards blurring of boundaries, who's doing what, and I think it's important to know that we have not found the right balances yet. Equally, the difference between the statutory and the independent sector, that includes voluntary sector as well, again, is something, a more recent development. Again, we don't have a balance on that. Third group of factors, unit of intervention. When do we intervene? Do we intervene on a liver? Do we intervene on someone's lungs that are being destroyed? Do we intervene on the level of the carer, the diet, the carer, and the service user, or is it the family, or perhaps the community? That kind of intervention has not received the attention it really needs. But hopefully things will be better in the future. Finally, very close to unit of intervention is the concept of the concept of prevention as juxtaposed to treatment. We operate on the principles of prevention, that they are being modeled around some illnesses that they have acute onset. It's one thing to try to prevent an element of sudden onset. Someone's break their leg, they get an infection. It's a different thing to deal with issues like substance misuse that erodes someone's function, and not only their systems, their organic systems. The last slide about the current challenges. Science versus practice. That's one we never got right in UK. Science operates on principles of theory and experiment and finding new knowledge. Practice is based on operating on evidence-based and being able to deliver outcome. There is a muddled thinking amongst those two very different concepts, and you cannot see nowhere more clearly than the second bullet point I have there about evaluation. People mistake the evaluation of a program with the evaluation of its implementation. So, for argument's sake, someone says, we're going to do this to help our scientists. We're going to give them 1 apple a day, for example. Someone could evaluate that program and then find out that perhaps by giving someone 1 apple a day, they make a difference to their lives, not because of the apple, because you take care of someone, because you show that you really care about who they are. And then you try to implement that. There could be 1,000 different ways of actually implementing it. No one would ever do an impact assessment. No one is a very strong term. No one would actually see how well that would be implemented. If you think the issue about Apple is very far-fetched, what about using any of the guidelines that actually has been issued in this country? They have very robust theory behind them. The research quoted there is mind-boggling. The way the research results were arrived at could withstand any scrutiny. Nevertheless, we don't make any progress because the implementation of all these wonderful things, it's not as good as the evaluation of how the knowledge was arrived at. Another very important point for this country is the concept of clinical governance. Clinical governance was introduced about 20 years ago, 1999 or thereabout, and the whole idea was about creating a system in order to have the excellence to thrive, do things better. Nevertheless, what we've seen in the system in the last 10 years, the addiction system, we've seen the change. We've seen a lot of new ways of doing things, contracts change, at least in the independent sector, in the voluntary sector, contracts change hands every couple of years, different cultures, different philosophies, different ways of operation. Nobody has actually prepared this country for change management. Everything is about clinical governance, and that's something we're missing. Well, the current challenges, I put the quality versus cost. And it's the last one of the challenges that you would remember. You will be relieved to hear. Last of the challenges I put in this talk. There are many others, but we have only 20 minutes for this talk. Quality versus cost. Sorry about that. Both of them, they are relative concepts. There's not an absolute measure of quality. There's not an absolute measure of what is good enough cost. Therefore, what happens as the years unfolded, we're seeing more and more gaps in quality between providers or between those who have less complexity of need and those who have far more severe, more complex needs. Equally, we see a cost, the gap between the available finances and what we're spending increasing, no matter what we try. So immediately, when I went through these 3 slides, the current challenges, I thought I would have been better off in that theatre with those kids, you know, at least would have been a fear, would have been over when the play, you know, finished. Here is something for the long run. Let's move on though, yeah, and let's not lose our optimism. Do you know what that is? Does anyone know?
Yeah,
what
when I changed over to the right instead of left in the traffic.
Fantastic. This is the H Day in Sweden. On the 3rd of September 1967, they changed from the left to right.
Was the 26th of May 1968 in Iceland?
Yes, they did exactly that, but they were the first ones who did it. Let me stay on this for a second. I wanted to put a picture just to break the text. And it's an interesting, very interesting concept, because you could see here in the second photograph I have from that time, quite a few of the vehicles going wrong way, you know, which was the right way, admittedly, because about 1 week before the H Day started, the starting point of what they've done in Sweden was this. They said, we are near Norway and Finland, and they are right drive, and we have so many accidents, so let's do it let's change it from left to right, like our neighbors, so that would decrease the accidents. That's what they thought. So they did all the consultations you could think of, all the preparations, and what happened 3 o'clock one night, the 3rd of the 9th, this is what happened. Everything stopped. Yeah, everything, literally. It was a holding in traffic, and they changed the other way around. It's a good story because it shows, despite this chaos, that they actually delivered what they wanted. With the preparation in changing this, they managed to go through the first few weeks with less accidents than the ones they had before. Yeah, that was a success to a certain extent. But let's stick with that paradigm. I'll come to that in a second. Not a second, it's probably about 5 minutes down the line. So we're coming to solutions now. We have some way of moving forward. We need to anchor our solutions of moving forward. Moving forward in what? I repeat, what I'm examining is about the global integration. Is it sustainable for addiction services to stay on their own, or should we look beyond what we actually deliver now? So the current anchor is the natural history of addictions. Provided that people survive, they do kick the habit. That's the principle behind it. Yeah. So let's keep that. Let's keep that the need decrease accessibility. The more need you have, the less likely you're going to access services. The less likely you're going to be able to do so. We also know that treatment protects. It's better to be in treatment than outside for a variety of indices. And we also know that pharmacology is not enough. So, with those anchors, let's move into theoretical approaches that we might have. The first one is about the theory of the communicative action. It's about Habermas, about how to do things, and all the people agreed to go forward. Basically talks about collaboration. I don't have time for this talk. What I do have time for this talk is to tell you a couple of minutes about the wicked problems. I don't know how many of you have heard the term wicked problems. Let's ring a bell, yeah? Okay, excellent. There's, I have 2 references there. Ritter from the 1970s who introduced the concept, and then I have Knapp from the first decade of this century, this millennium, addressed that. And what a wicked problem is a problem that cannot be clearly defined. It's complex, and we cannot identify the causes. And everything we say might be a cause is interconnected with everything else. So needless to say, it's so vague. There are no known solutions. So there's an enormous amount of literature on this, on the wicked problems. Anything that has to do with major systems. The reason being that it's a common experience nowadays to be able to change systems and being unable to do that. But we don't give up hope, because the literature of wicked problems gravitate into the fourth item, the 4 bullet point, that actually it's time to probably be a test, I think. And giving the emphasis, and my time is up, and could you be more discreet, please? Now, but we were talking about the partial solutions, sorry, last bullet point, I finished. So, in what happens to wicked problems, we cannot define them, we cannot find solutions, but you can find partial solutions. So it's perfectly legitimate to try to solve only part of the problem the way you define it. The idea being that you move whatever the system is with its wicked problem to someone closer to a better state, and then you're dealing with what's left with perhaps another partial solution. Partial solutions are called interventions, at least with one school of thought in the wicked problem paradigm. And it's important to remember that, for this talk at least, that the interventions are basically defined either those that are authoritative, someone orders people to do things. The government, might say this is how you're going to be dealing all the addiction services, and the non-addiction would be one entity, for example. And then there is the competitive mode of interventions, which is you let the market decide. The major drawback is that you don't share knowledge easily if there's a competitive environment. And then there's the last type of interventions, which is the collaborative ones, which is something that I personally favor. Earlier on, I talked about Habermas and communicative action. This is a tool of working collaboratively, but as I said, it's beyond the timing of this talk. So what sort of interventions we have for wicked problems? How would we, main problem I'm trying to sort out is that, global integration or stay on our own in addiction services. And this is the best intervention in my mind for wicked problems. Does anyone know the name of this? Yeah, it's a peloton. Shame on all those physical exercise freaks who do, with day in, day out, they're on their cycles. I tell you, this is the best example that does exist for me for collaborative work, because what's the idea behind the peloton is that people, yes, they compete for being on the podium, first, second, and third, but the bottom being first to begin with. But the bottom line is that unless you join forces, the wind, the resistance of the wind, would destroy you. So all the competing forces, they work together throughout the course in order to release the winner at the very end. For our intents and purposes, for what's happening in substance misuse, in addiction services, the wind, the big problem that we have to deal with is the complexity of the issue, is the fact that the system is complex, that it's a system that can only be dealt with as a wicked problem with partial solutions. So in conclusion, global integration, could be addressed as a wicked problem that's amenable to partial solutions, the interventions, as I said, that they should be collaboration-based. So my view is that we could move, in order to be sustainable, we need to collaborate outside where we are at this point in time. I tried to show you that in this analysis by just highlighting the UK experience without putting too much data, too much numbers in it, because of the time of the day, and you seem to be like, good people. Thanks.
Please. The question is, like this. I think this will be in all.
come to these kind of things, you actually thank people for inviting you. I think it's probably appropriate to thank people for staying. This really is about as graveyard as it gets. I think it's interesting because although my presentation is really looking at the integration of mental health and substance misuse, I really wanted to take it a little bit beyond that and actually talk more about sustainability. Because is anybody here from the UK? I'm just kind of interested in a kind of mix. So it's mostly UK. Okay, well, most of what I'm talking about is very much about the commissioning environment in the UK. And I think it's sort of fairly clear now that the budgets are likely to continue on a downward trajectory. I think we all need to start thinking very creatively about how we deliver our services. I don't think that's going to be easy. I think we're presented now with some pretty enormous challenges, but I don't think we're going to overcome these challenges unless as providers we start to work a lot more collaboratively. And it was interesting in the presentation I've just been in, which is a really, I don't know if anybody was in here, but it's a really dire kind of presentation of the sector that we're in at the moment. I would actually say, having worked in the sector now for 14, 15 years, that I think we have to take a lot of ownership of that. I was really shocked when I came into the centre because I'd actually previously worked in the private sector. And one of the things that really struck me coming into the voluntary sector was just how competitive voluntary sector organisations were with each other. And in many ways, there seemed to be quite a significant lack of collaboration. And that really surprised me. I really thought I was coming into a sector where we were all going to be one happy family and it didn't really matter who you were working for, but we were all going to be working fairly well together. I don't think that really happened. But I think if we're talking about sustainability, I also want to talk about the commissioning environment and how our services are actually commissioned. And is the way that they're commissioned, does that actually aid sustainability or does it actually get in the way of that? And I think that's probably an issue that we really do need to start thinking about if we're going to talk about sustainability. I think that's a real thorny issue, so I'll talk a little bit about that at the end. But I wanted to go on to what I wanted to talk about, the integration of mental health and substance misuse services. When I first started working for RAPT, I was overseeing two prisons, not other prisons, but two prisons in particular, which was Grendon Prison and Aylesbury. Now, I don't know if anybody's familiar with those prisons, but Grendon was a prison that was set up to deal with people with personality disorder. A lot of people there are serving life sentences. Aylesbury Prison is a young offenders institute, and the people working there's quite a lot of lifers in Aylesbury young offenders as well. And what really struck me was just the level of mental health problems of the people we were working with in Aylesbury. And the issue for me was that Aylesbury was not in any way, shape or form a particularly therapeutic environment. We had a therapeutic environment down the road in Grendon, which was set up to work with people with personality disorder. And I was working in Aylesbury, and they had an education department, that was all great, and they did bricklaying, and they did all kinds of stuff like that. But what they weren't doing was really addressing the fairly significant mental health problems. And at the time, I thought, well, I had a hypothesis. It's always good to start with a hypothesis. My hypothesis at the time was that if there wasn't a therapeutic environment in Aylesbury, that the young people we were working with in Aylesbury would become the Grendon population of tomorrow. So at the time, I don't know if you know him, there was a guy called Norman Hoffman, who's an American psychologist, and he'd done quite a lot of work profiling drug, alcohol dependency and mental health in American prisons. So I got together with him and I said, listen, I'm really interested in these two populations. Can we do a piece of work together? So we did. And the results weren't all that surprising. We found lots of similarities. In fact, we had more antisocial personality disorder in Aylesbury than we did even in Grendon. A lot of same profiles in terms of the mental health, but the thing that really surprised me at the time was the high prevalence of post-traumatic stress disorder. Because We talk a lot now, I think, about the high prevalence of post-traumatic stress disorder, but this was like 12, 13 years ago, and we weren't really talking about it then. And I think even though we talk about it now, there is often a tendency to talk about it very much in terms of the female prison population, and while they do have slightly higher levels of prevalence, the level of prevalence of trauma within the male prison population is high, significant. Now I'll try and get onto one of my slides. Oh, there we go. I was actually going to skip through this slide because of time. But one of the things I just want, this is really about the RAP approach, and it's extremely interesting. But I think one of the main things I want to really highlight is that we have very much moved towards a model where we integrate mental health and substance misuse. And interestingly, when we introduced that and evaluated it, what we saw was that our completion rates increased significantly. They increased from 68% to 78%. And that was, in those days, a 65% completion rate was regarded as pretty impressive. But actually, 78%, that's pretty good. I think my next slide is, no it's not, that's my last slide. Okay, following on from the work I've done in Brenton and Aylesbury, what I started to do then, with everything that came into our programs, I carried on using the CAAD, which is what Norman Hoffman had developed. And I started using that assessment on everybody that came into our programs. And because I was struck by the number of people who came with trauma, and I wanted to find out, was that something that was common, or was it just because these were two particularly distinct populations? And I'll just, to let you, this is based on 3,000 people who came into our program between 2011 and 2014. So it's a pretty good sample size. I think the stats that we found, I think they're fairly trustworthy given the size of the sample. And as you see the percentages, if you can see them from there, they don't add up to 100%, and that's because most people present with multiple issues. And I don't want to go through the prevalence data, but you'll see from the results there that trauma symptoms were reported by 74% of the people, and half met the criteria for post-traumatic stress disorder. When we were going through the process of reaccrediting our women's program, I decided that it was probably about time, and I should have probably done it before, to do some research about approaches that address trauma and substance misuse. And I came across, when I was doing my literature research, which was extremely intensive as it is, I came across several references to an intervention called Seeking Safety. I don't know if that's something people are familiar with. Okay, well, it's an approach that was developed by an American psychologist called Lisa Nanchkovitz. And what I really liked about it, what I was really attracted to about it, was that it was an intervention that was very much based on dealing with symptoms and not going into the event. And that seemed to me to be highly appropriate. Because the people we're working with in prison actually present with developmental, not single event trauma. And I think that distinction is incredibly important, because people who've been traumatized as children, they don't often make that link between their behavior, the way they feel, their hypervigilance, and what happened to them as a child. And so the conclusion that I drew from that, which is in some ways fairly obvious, is that it's very difficult for them to sustain their recovery. Is if you get into recovery and all of those hypervigilance start to emerge again, then it's not easy to kind of wonder why they don't keep into recovery. And it also was an approach that made a lot of sense to me, just even because of the name, Seeking Safety. I was attracted to that as a name because an awful lot of the people we work with don't feel safe. An awful lot of the people that we work with put themselves into very risky situations. Okay. There are three key pieces of work that we've undertaken. Oh, I got back to time. Looking at the link between mental health problems and substance misuse. Just going to these really briefly. We submitted the names of people who'd engaged with our program to the MOJ. They then supplied us with all of the reoffending data of the people that we submitted. We then cross-referenced it with our database to try to find out if there was a link between the mental health problems and the reoffending. Now, I'll tell you the results on the next page. Okay. There was another study that we did where we explored the impact of our programs on pre and post levels of anxiety and depression. The poor guys, they had to repeat the psychometrics after the program, but we really needed to know whether we were having an impact. If we were talking about we are doing a holistic intervention when we're working with mental health and substance use, we really need to know whether we're making a difference or not. We also held quite a lot of focus groups with service users to try and get a better understanding of, how they perceive the integrated service. Did they see it as being integrated? And this is our findings. Probably can't read them from there, but I'll go through them. A history of depression and personality disorder came out as predictors of reoffending post-release. Now, personality disorder wasn't something we were all that surprised about. If you look at any studies, personality disorder comes out as a significant factor in reoffending. But we were a little bit disappointed to find out that depression wasn't significantly reduced, the impact of that wasn't significantly reduced by our program. But we were encouraged that anxiety and trauma were predictors of post-release reoffending. But I think we're still faced with the challenge of finding out different ways of working with people who present with depression or histories of depression. And particularly so because our pre and post psychometric measures indicated that they made comparable gains with everybody else on the program. So what became quite clear to us that they may make comparable gains, but they find it very difficult to sustain those gains. So what kind of follow-on aftercare we need to provide for that particular group. This is just the other one. When we looked at mental health symptoms after completion of treatment, we did find a significant reduction in the anxiety, depression, and so on. So we could feel fairly confident that the approach that we were taking was actually working. The focus group with service users I found absolutely fascinating. I think what really fascinated me was the whole issue around trauma and what is the difference between people with developmental trauma and people with single event trauma. Because what we were finding was that the very naming of some of those symptoms in and of themselves created an incredible sense of relief for the people that we were working with. It had, I called it a Rumpelstiltskin effect. I don't know the fairy tale about Rumpelstiltskin. It seemed to me that with the people that we were working with, there was actually a sense of freedom just in the naming, that the hypervigilance around the risk-taking behaviour, that actually these things could be linked back to their early histories. And because it was developmental, they were much more inclined to see it in terms of their personality. This is who I am. They weren't making that link. And what was really interesting, one of the people that I spoke to said that they felt actually quite angry. Sorry, angry. I said, I've been in and out of treatment and nobody's ever spoken to me about trauma. Nobody's ever made that link between how I feel when I get into recovery and what happened to me in the past. So I would strongly encourage that we really do think about how we integrate these types of services, because I think, when I did the research back in Brendan and Aylesbury, I was really, really surprised at the prevalence of trauma. I don't think it's just an issue for people who are in prison. I think you may well find that a lot of people who present with substance dependency have got histories of trauma, and it's likely to be developmental, and they're not. There's a high chance that they're not making that link. Okay, so I think I want to just say some general points. I think we can make our services more sustainable by integrating substance misuse with mental health. But I think we need to be a lot clearer about what those services should look like and what the essential ingredients are of an effective service. And I think we've still got a long way to go. And I think that also raises something that I think is terribly important. I think as providers of treatment, when we research our interventions, I think we should be really open about what works and what doesn't work. We know we've got an issue with people who present with depressive symptoms, and we really need to start looking at how the aftercare that we provide. And I think if, as providers, we can be a lot more open about our successes and also about the things that have not worked terribly well, then I think we're really going to make a step forward. Now, and finally, I'm not going to let commissioners off the hook. So I want to make some general remarks about the commissioning landscape. I think commissioners are starting to recognise the importance of integration, but all too often, this is coming under the general banner of health and well-being. Substance misuse and mental health services, I think they're going to start to be commissioned together, but the specs that I've looked at so far ask them to be delivered sequentially or in parallel, and that's not integration. Okay. One statement. I should have checked if there are any commissioners in the room, shouldn't I? So I'd suggest that if we want our services to be sustainable, we need to start talking about real integration rather than parallel or sequential integration, because I don't think that works. But I want to end on a really positive note. We just won a really large contract in East Kent, and it was incredibly attractive, not just because it was large. It was attractive because it was really the first time that I'd seen a substance misuse tender that was actually saying, what I want you to do is, if I award you the contract, I want you to come in, and I want you to work with me, and I want you to work with the service users, so that between us, we can develop a service that best meets their needs. Now, I thought that was an absolute breath of fresh air, because I'm much more comfortable with a commissioner that says, my budget's been cut by 20%, so can we sit down and talk about what our service is going to look like with a 20% reduction? What I don't want, and I'm sure you guys in the sector have seen this in the last few years, is where you get a tender coming out, you know what the value of the contract was, and you know what they're now putting in the contract, and what you're seeing is a 20% reduction and a 20% increase in what they expect. And that isn't sustainable. I think what's sustainable is the approach that's taken by the Commissioner down in East Kent, which is let's all sit around the table and let's figure out how we can deliver this service with a reduced budget. So I think, we really should start trying to persuade our commissioners, perhaps talk to Public Health England about the fact that this is probably the most sustainable way forward, is to actually let's sit down and let's talk about what we can do with a reduced budget. Okay, thank you. Thank you for staying.
Thank you very much to Ray, Kostas, and Gail. I just want to, because we're coming to the end, I think I'd just like to summarize a few things and maybe go for a few questions, but very, very simple way. First of all, the closed system, forget about prison, the closed system you can work on within is productive. That's the first thing I take here. And I concur with the trauma and the addiction. A lot of research outside of prison are absolutely similar, nothing to do with offenders. So that's the first thing I take. The second thing I take is that The process of change in integration is not a black or white process of change. I like the wicked conceptualization here, and we have to be very humble and modest with that. The third thing I take is that a lot of people don't want to integrate, and I'm speaking from the medical non-addiction group, and this is from the US. I also realized that a lot of things we've done in the past years, and that was an epiphany for me, right, stem from the fact that no one really wanted an alky in their services. And I never thought about that one. So we had to develop our own services, and it informs the history. So we've got all those different angles. The last thing I want to name, and I feel really sad about that, the way we monetize and over-monetize human life and human death by making things a business, making things a commission, making things about productivity of a bed like a hotel, and so on and so forth, is just shocking. Because the reality, speaking just for addiction, is that there is 7-8 million people dying every year, 1 addict dying every 4 seconds, in the world. And this is maybe 3 to 4 times more than conflicts and war, and I'm quoting the UN and WHO there. So it is quite shocking. Now, with that, please, can we have the mic and ask questions? Denise.
Thanks. This is not a question, just a comment. And I just want to say thank you so much for this presentation. The diversity in the content is tremendous. And I have to say I'm very, very grateful for it. And Ray, very happy to see you representing the US. Thanks.
Since we unfortunately live in this system where it is a capitalist system and that's patients are monetized and so the beds, etc. Well, I'm wondering, Ray, you were talking about sort of payers in the United States, and I certainly work in the States, and I understand how that works. But I'm wondering if paying everybody, every provider, the same amount, like in-network contracts, and I have an understanding, although it's sort of fledgling, that it may work the same way here. The NHS sort of sets a standard, and then they reimburse providers. I'm wondering whether the idea of value-based services would be better met by sort of paying providers who actually have results and have outcomes and who provide excellence, because then it would be using that system and that market-driven system to actually produce better outcomes. Because if everybody's getting paid the same, and you can cut corners and skimp and do the very least that's necessary, as unfortunately I've seen in the United States, then what's your incentive?
It was the worse than that because there's a dichotomy between in-network, so we're getting in the weeds here, but in-network contracted providers who negotiate a rate with an insurance carrier. Generally it's a negotiation, so you're not going to get what you think you want. Versus what we have in the States now is a plethora of out-of-network providers who don't contract with the insurance companies. And the way the insurance contracts are written, the insurers have very little ability to govern the amounts that these folks charge. So for instance, if an in-network provider of a service called intensive outpatient, which is sort of like a day program or an evening program, an in-network contract provider will get somewhere between $150 and $200 per day for that service. That's a 3.5-hour service. An out-of-network provider, and I know some of them, are charging up in the area of $1,000 a day for that service. So it's a tremendous high margin service. So those inequalities, I mean, it's just a matter of time before they figure out how to deal with that, and that's going to put a tremendous dent into the profit margins of providers who are frankly financed by private equity investment in the United States, because it's a very high margin service. If you're a narrow provider that's only providing services to folks who either have resources or have commercial insurance that pays much better than a public rate. So you have this sort of bifurcated system of for-profits that take care of people who are able to pay, and they're looking at 20 to 25% margins on revenues, and then sort of not-for-profits that are taking care of everyone, who are operating more along hospital margins, which are anywhere in the neighborhood of 3 to 5%. You have an unsustainable system ultimately for those folks because they just don't have the capital necessary to grow services, to invest in technology, and to do the other things that elevate the quality of the service. So the have-nots will get this, and the haves will get that. I mean, it's just not a good situation there, but it's sort of what we have. And my conviction is that over time, once the sort of rehab bubble bursts, we've been through this in the States. We went through it in the early 80s, and the bubble popped, and all of the high margin services said, "The hell with this. Let's turn this into a assisted living center or a head injury clinic that can generate the same profit." So that will end up being bad for patients who won't have as many places to go.
Thank you, Ray. I understand that actually globalization leads to less margin than specialization as a global understanding of the economy of the sector, which is probably the big block to thinking of the best help we can give to patients, right?
Globalization does.
Yeah.
Yeah. I mean, the more you go out to develop services along the sort of continuum, if you will, the smaller the margins become because they're less profitable investments. That's why you have when I say private equity investment in American rehab business, we're talking hundreds of millions of dollars.
Thank you.
So I just want to understand what the.
I'm going to give you a mic.
I'm sorry.
The filming of it. Thank you.
I'm just trying to understand a little bit better what you're saying. What the you know, if there's a cultural thing in there as well in terms of how these services are thought about, because I know I'm just trying to compare it with my own experience of private versus NHS physical healthcare here, which I've experienced both, and I had like a cancer treatment in Harley Street. But effectively, it's like having it in business class, if you know what I mean. So the consultants were the same. They worked in the NHS. The medication and the course of treatment that I received was the same as I would have received in the NHS. And the staff were the same, you know, the surgeon, the oncologist, So but that's not the case when in this field. You know, so that the publicly available services are very different to the privately available, and I wonder what the it's a question of how it's perceived in the culture. You know, that the consultants in private practice here, in order to have credibility, need to work in the NHS. It's not the same situation in addiction and healthcare and mental health care, is it?
No.
And I just wonder why that is.
Kostas, would you like to answer for the NHS?
I can take that. It's not true in terms of the professional aspect of what you mentioned. It's very, very important. If you're going to be able to claim that you're an addiction psychiatrist, that means you really had a very long training within the NHS training schemes. There isn't, at this point in time, we don't have extensive training outside the NHS. We are one of the very few organizations, one of the first in the third sector that actually managed to get approved training for addiction psychiatry. But having said that, what you mentioned at the very start of this sentence, in order to have credential within this country, you need to have at least a significant presence as a consultant in the NHS is true for the secondary care. The thing that's slightly different in addiction in this country is that you could be a GP with special interest. That means you could have been a partner, a good GP nevertheless, but you don't need to have shown any particular affiliation or training in a particular area to do that. You need to have the credentials, you need to have the training to be able to claim that you're a GP with special interests. So in what you described early on, both in terms of the credentials of the professionals who treated you in medicine, in physical medicine, it's the same thing about addiction, not different at all. Equally, I would suspect that the difference in terms of how much money it costs, it would be the similar scale within the addiction services. The reason being is that you have different types of overheads that you need to be dealing if you're in the NHS relative to if you're in the private sector, and that's basically what the difference is. Sometimes it's higher in the NHS, having said that, run in addictions.
Thank you, Kostas. It reminds me of something I just want to share with you very briefly. I was taking in a patient in this private hospital in North London, and I didn't have any addiction nurse with me, so I had a general psych nurse, and I said, we need immediately a breathalyzer, because we need to breathalyze this woman because I need to make the evidence about how much she's intoxicated. She did it 48 hours after. And then I challenged her. I said, it's not really useful because we needed something there, and it decreased 0.1 an hour. And she said, I didn't know. I'm not trained for that. I'm in this private hospital in North London. I'm not giving any name. I worked there a few years, and that's bad it is. And what you said, Kostas, about the training of the consultant and the medical doctors is absolutely true. Now, I have a big question about the level of not the qualification, but the capacity of the therapist to take all that charge on them, because psychotherapy is the battlefront, and the psychiatrist is there to guide all that. But when it comes to trauma, dealing with developmental trauma requires specific training for a therapist. It's tough, and it's not that easy, and combining with substance misuse. I just want to close because we're running out of time. We're not at the end of this debate. It seems to me that the globalization is going to be a very difficult challenge. We could, and the lack of funding will block it big time. It works in a closed system, and I want us to remind that. It works in a closed system. You achieve results because you have people, they're there, they're available, and you have also a team who's dedicated to the closed system. That's so important. And,
they're going nowhere.
Yeah, they're going nowhere, absolutely. They keep coming back. Yeah.
And they turn up.
Yes, exactly. And by the way, the similarity between the reoffending rates is very similar conceptually to the readmission to the hospital you discussed about. And I think there's a lot to be taken out of what you presented in terms of how we can do that in a semi-open system, which is the kind of civilization we live in. But things work in a closed system. This is the most important thing. So globalization can happen if we cluster something there, I think. I need to, yes, we run out of time, sorry. Thank you very much indeed.